let's talk about maybe the emetogenicity of some of the newer agents and some of the things that we heard about at ASCO this year. So we hear a lot, obviously, about immunotherapy. Generally, I think it's fair to say those drugs are very low emesis potential. We also heard a plenary, though, about using oral agents and for brain cancer, and that may be Temodor is moderately to highly emetogenic. So how do we integrate the guidelines on oral therapies? Jim?
As far as I know, I think NCCN, right, is the only guideline that even comments on oral chemotherapy, at least at this point. And it is definitely a challenge with the oral chemotherapy agents, and they're not going away. As I mentioned, there's a bunch of new drugs coming out, and most of them are oral.
Right.
Because I write up those drug information sheets for the practice, so yeah. I'm well aware of those. But it is a challenge, and I don't know if we have a good handle yet on what's the appropriate way to do it. Certainly, we follow the guidelines. We give antiemetics prior to the oral agents that are deemed to be moderately or highly emetogenic. But I don't know if we necessarily have the right answers yet, if that's the best way to do it.
And part of that, it hasn't been studied well.
And
it's not easy to study well, because we've talked about doing studies for it, and Rebecca knows most of all this. She's just holding back from all of us, I think. But I think it's just not been well studied.
Yeah, how do you handle that with your patients?
I primarily see breast cancer patients, but I think the point is the guidelines are being updated. ASCO's in the process of updating their guidelines and will hopefully include this information as well about oral agents.
Yeah, so I approach it from a very practical sense where we don't have great information, and I really start thinking about these patient risk factors. You know, even if they are getting an oral agent, but they have a bunch of these risk factors, I tend to be more aggressive about my prophylaxis, just because I know if they have a bad experience with the first cycle, they're going to have a bad experience with all the further cycles. So really being aggressive about that prophylaxis initially, and then you can always, as Charles kind of pointed out, you can then back off a little bit. But the challenge with this, again, is the drug-drug interactions. So you really need to get your pharmacists involved and really talk about it, because it turns out that you're going to be getting a lot of phone calls about it.
It's very underappreciated, the amount of interactions. That,
So let's focus for a minute on the patient risk factors, particularly when it comes to moderately emetogenic chemotherapy, which we already said is a very wide range, 30 to 90%. And there's a big difference. That's a threefold range. So somebody with drugs that have an intrinsic 30% versus those that bump up to the 90%, we might approach those differently.
Yeah, and I think we're seeing some changes even in our guidelines. So, MASC recently bumped carbo. You can either say it's high risk for moderate or
Low risk for high.
Low risk for high. And, some of us sit here and argue about these things, but they're saying carbo is really that we should be treating it now with 3 drugs instead of 1. So for me, that's really in the moderate emetogenic chemotherapy setting, we really need to start thinking about these risk factors more. And then, I anticipate there's going to be studies coming out, Charles, about the combination of these patient risk factors with the chemotherapy risk factors to help us make better decisions, especially on system-wide basis. But at this point, it's still kind of that gut check.
So how do you use that in a moderately emetogenic?
So I don't know that I don't know of any actually pending data that are coming out with the patient symptoms. They should be collected. Maybe we'll get information. With all this discussion, it makes me think also that not just oral chemotherapy, but if we give 5 days of chemotherapy in a row, we don't know what we're doing there very well either.
Definitely. Very
and the
data.
Long-term oral chemotherapy, as a breast oncologist, capecitabine, but it doesn't usually cause that much trouble, and so I usually don't give anything there, and if they get something, they give ondansetron or something like that, a 5-HT3 receptor antagonist is what I end up using in that setting, but it's not that often for it. But it's the same sort of thing with the multi-dose regimens. And I don't treat the brain tumor patients, so I don't know how much nausea and vomiting they actually have, but I suspect that it's 5-HT receptors they're given as opposed to NK1 receptors or chronic steroids. Those are your other choices.
There's really very little data.
Yeah.
There was just actually a randomized trial in chemoradiation together for a 5-week course where adding a 3-drug combination once a week helped that. And that's the kind of thing that I think we have to do. And I think for these chronic oral therapies like in lung cancer, the ALK inhibitors have a fair amount of nausea. And so those are the kind, my concern there is patients are at home and then we don't know if they're taking, if you have nausea every day, you might skip a day or two of drug and it might really impact these patients. So it's
Yeah.
kind of an untested field yet. And I think we need to do a lot more trials there.
Yeah, and you could argue that kind of chronic low-grade nausea is almost worse than just having a really bad bout of nausea and vomiting and just get it over with. And so I think my nursing colleagues are teaching me that we need to ask about nausea in maybe more subtle ways, like how is your eating?
Well, and that's important too, because I think nausea is different
Yeah.
for different people. We really don't, I think each of us may have an individual idea of what it is. And for patients, it's the same thing. So,
That's why some of the recent trials are looking at no nausea
Yeah.
for 5
Yeah.
days, which is a pretty high bar to get over. No nausea for 5 days as opposed to mild nausea. What the heck is mild versus
Yeah.
moderate nausea?
I mean, it's so subjective. If some patients say, well, I couldn't eat.
Right.
And that to them is nausea.
A bad taste in your mouth
Yeah.
or grumbling in your stomach or anxiety can often be interpreted as nausea as well.
And then why we care is that it impacts whether or not they're compliant with their medication, and it impacts how
Exactly.
aggressive we can be about treating their cancer. So this matters.
And it impacts how they function in their life. So if you have that moderate nausea, but you never have to take a rescue medicine, which is the way we define efficacy in our clinical trials, not really a true endpoint, a real life endpoint. You can't go to work, you can't take care of your kids, and you just feel lousy. It's a big deal, as everyone has said.
Absolutely.